Okay, thank you, Stephen, for the nice invitation, and it's an honor for me to be part of this 22nd edition of this symposium. So I will get started. Can you see my slides there?
Yes, it looks good.
Okay, that's great. So I'll talk about the complement cascade in COVID-19 and how we use that in a clinical trial to address this question. So as you may know, the pathogenesis of COVID-19 is quite complex, but you have in patients who have a normal immune response, the virus might infect the cells, and this triggers a immune response in which the cells that are infected will be rapidly cleared by the immune response by attracting neutrophils and macrophages to the site in the airways, and the virus is inactivated by neutralizing antibodies, and this results in minimal inflammation and lung damage in these patients. However, in the percentage of patients, the inflammatory response may be hyperactivated, and this may be related to a cytokine storm. So you have excessive infiltration of the airways with monocytes, macrophages, and T cells, as well as the systemic cytokine storm leading to pulmonary edema, pneumonia, and also a widespread inflammation and multi-organ damage in the patients. You can see that there is an increase in the vascular permeability, and part of this is mediated by the complement cascade. And the complement cascade may be activated via different pathways through the virus. So the virus might activate directly the lectin pathway, or the presence of antibodies and immune complexes might activate a classical pathway, or toll-like receptors might activate the alternative pathway of the complement. No matter what pathway is activated, this will eventually lead to C3 cleavage, generation of C3A, also C5A, and these molecules will eventually start or trigger the cytokine storm, attract neutrophils and macrophages to the site, to the lungs, and cause the hyperinflammation that we see and the acute respiratory distress syndrome that is clinically manifested in these patients. So potentially, this activation of the innate immunity in the lungs in patients that is the result of this abnormal inflammatory response might be a target to prevent the hyperinflammation and the damage to the organs in patients with severe COVID-19. This hypothesis is supported by some experimental evidence a couple of years ago using a mouse model that was a knockout for C3, and these animals were infected with SARS-CoV, not SARS-CoV-2, but SARS-CoV, and whereas the wild-type animals that were infected with SARS-CoV had very early deposition of C3 in the airways. You don't see that in the animals that were C3 knockout. Also, within 24 hours from infection in the wild-type animals, you can see C3 be deposition in the lungs, and this is not seen, of course, in the C3 knockout animals, and this might also relate to in the lungs in the animals. Also important, the profile is different in the knockout animals. So we can see here in red the wild-type animals, and the blue bars represent the C3 knockout animals. And as you may appreciate, the cytokine store or the cytokine levels, for instance, GCSF or IL-1 alpha, TNF alpha, or IL-6 are significantly reduced in the animals that were C3 knockout, suggesting that the cytokine, the complement cascade, is pushing this cytokine storm. And we also see less migration of myeloid cells, including neutrophils or monocytes, to the lung sites. Well, if complement might be a target for this therapy for reducing hyperinflammation in COVID-19, we have to appreciate the entire complement cascade that is quite complex. And we have almost a dozen different targets today, either that are already being used in the clinic or are in development. For instance, C1 esterase inhibitor is used in the clinic to treat hereditary angioedema, but also for a longer time, for about 20 years, we have Kudusumab, that is a humanized monoclonal antibody against C5 here, and it's used to treat the hematological disorders, paroxysmal nocturnal hemoglobinuria, which is a intravascular hemolytic anemia, or atypical hemolytic uremic syndrome. But there are also other drugs here, either factor B inhibitor, factor D inhibitor, and C3 inhibitors. And I'll call your attention to the C3 inhibitors because there is this third generation comstatin, that is this drug that binds to C3, and the drug candidate is ME101, developed by John Lambris at the University of Pennsylvania. This is a C3 inhibitor peptide. It's much cheaper than monoclonal antibodies. It has good solubility, plasma half-life is pretty long, and the toxicology is quite good in early non-human primates and in human tests. No severe adverse events. And this is a Kudusumab, that is this anti-C5 humanized monoclonal antibody, and this regions, they recognize C5, and this has been used for about 20 years to treat patients with PNH, paroxysmal hemoglobinuria, paroxysmal nocturnal hemoglobinuria. This is the example of the pivotal study in which LDH, the lactate dehydrogenase levels in patients treated with Kudusumab. You can see the very severe drop in LDH, indicating very efficacious complement inhibition. And we are in hematology, we are very familiar using this drug and with the side effects and how safe complement inhibition is to treat patients with PNH. So having that in mind, John Lambris at UPenn designed a compassionate use program for ME101 that inhibits C3. And here at the University of São Paulo in Brazil, we conducted a small phase 1/2 single arm study to test a Kudusumab, which is the C5 inhibitor monoclonal antibody, to treat patients with severe COVID-19 that were positive by RT-PCR, but they have a good performance status previous to the infection. They should not have septic shock or multi-organ failure at the time of randomization or cancer or major surgery. These patients received penicillin prophylaxis to prevent potential encapsulated infections because of complement inhibition. And these patients received up to 3 doses weekly, intravenous doses weekly of 900 milligrams of Kudusumab. Most patients received only one dose. In the John Lambris's compassionate use program, patients also had positive RT-PCR. They have acute respiratory distress syndrome, signs of hyperinflammation. They should not have bacterial infection or being receiving immunotherapy. The way the drug was given was continuous IV infusions at the 5 milligrams per kilo per day, and patients received the drug until they were free of supplementary oxygen, or they didn't have evidence of respiratory failure anymore. Well, for the Kudusumab trial, 12 patients, this was within 6 or 8 weeks. 12 patients were eligible for the study. 2 refused to participate. 10 were enrolled. 8 of them were males. The median age was 52. 2 of these patients were already for a couple of days on mechanical ventilation by the time of randomization. And 1 patient was intubated within 12 hours after randomization and was extubated within 7 days after intubation. 2 patients died. These were exactly the 2 patients that were on mechanical ventilation already by the time of randomization on days 18 and 19. I'll talk more about that later. And these were the severe adverse events that we observed, and they were not really attributable to the study drug. On the compassionate study led by John Lambris, 3 patients were enrolled in the San Raffaele Hospital in Milan, Italy. They were all males. They were a little bit older than the patients treated here in Brazil, and none of them was on mechanical ventilation. So I'll show you the results on the effects of complement inhibition for in the hyperinflammation. So we can see here on the left side in orange, the patients who received ME101, that is the C3 inhibitor, the serum IL-6 that is central in the cytokine storm, you can see a steep decline in IL-6 serum levels in these patients. And we also saw that in the patients receiving in Coagulation. And that was quite fast. On day 2, the IL-6 levels were quite low already. So it's a very early response. The lactate dehydrogenase levels also decreased very fast in both groups. This is a normalized LDH levels in all patients. And we can see that the reduction in the LDH level was similar, whether in blue, patients were receiving Kudusumab inhibiting C5, or in orange, receiving ME101 inhibiting C3. The C-reactive protein levels also in most patients reduced very dramatically, and that was similar in both groups. But I'll call your attention to patient number 1. That is this one that had a decrease in the CRP levels, but at the end of the second week, there was an increase. This patient was diagnosed with pneumonia related to mechanical ventilation and died on day 19. This patient was already on mechanical ventilation when he was randomized and started receiving the drug. And we were able to do a minimally invasive autopsy in this patient, and this is the lung biopsy. And we can see here in the lung biopsy in the minor approach that there is this very severe fibrosis in the lung tissue. This might explain why we're unable to wean this patient off mechanical ventilation, although the inflammation parameters were better. And we can also see some hemorrhage within the airways, and that might indicate some damage and some pressure damage related to mechanical ventilation. But this shows how dramatically fibrosis might develop in these patients with COVID-19. Still on the hyperinflammation, this is when we were able to start to see some differences, whether we're inhibiting C3 or C5. So in orange, patients who had C3 inhibited, we can see that the neutrophil extracellular traps, nets, the net release was reduced in these patients, whereas we could not really see a reduction in net formation in patients receiving Kudusumab, and that's quite interesting to understand why these differences occur. We also looked at coagulation markers, and this is the D-dimer levels. Although it's hard to interpret, the dynamics of the dimers in these patients over time, but we can see that the reduction was pretty much similar in both groups. We also looked at thrombin, antithrombin levels. This might be a little bit more sensitive in terms of the generation of thrombin in patients. We can see that there was a decrease in patients receiving eculizumab and a decrease in patients receiving AMI-101 drug. So this was pretty similar in both sides. And we also looked at how the complement cascade behaved, whether we were inhibiting C3 or C5. And this is quite interesting because if we go to the right-hand side here, this is the hemolytic activity of the alternative pathway test. So we can see that patients who received AMI-101, you have pretty much virtual 100% inhibition of the complement activity. And this is, these are the patients who are receiving continuous infusion of the drug. So up to day 7, the complement hemolytic activity was pretty much 0. Whereas in patients receiving eculizumab, we can see some residual complement activity that was on day 7, just before the second dose, for those who received the second dose of the drug, was about 8 to 10% of hemolytic activity of the complement pathway. It's hard to know how significant that is to the activity of the hyperinflammation in these patients. We also looked at the C3A levels in the plasma, and we can see it, which is interesting, there was a decrease in patients receiving eculizumab, although the blockade is at the level of C5, so it's downstream from C3A generation, but still we can see that it goes down. And patients who received AMI-101, the decrease in C3A generation is much more dramatic than those who are receiving eculizumab. Which was also interesting is that we measured the factor B levels in both groups. And I'll call your attention to the fact that patients who received AMI-101, the factor B levels were pretty much stable over time. However, patients receiving eculizumab, that is a C5 inhibitor, we can see that there was a decrease in the factor B levels. One way to explain this difference in the patterns of factor B levels might be that Soliris, which is eculizumab, inhibits C5 that is downstream from C3 convertase. So here we have C3BBB that has the amplification loop, and you have C3, and this is this amplification loop might still be active in patients receiving eculizumab. And in this loop, you have the BA that is part of a factor B consumption that fuels the loop. So if this loop is still active, you might have some factor B consumption. And this might explain why there is some factor B reduction in factor B levels, serum levels in these patients. And along with the C3A levels that decrease not as much as in AMI-101, that makes sense that in some part, this loop might be still active in patients receiving eculizumab. What is much harder to understand, and we don't provide a significant explanation for this, is the levels of the soluble membrane attack complex, that is the SCS-C5b9. And what we observed is in the patients receiving eculizumab, we found an increase in the soluble levels of the MEK, whereas in patients receiving AMI-101, there was a reduction in the serum levels of the soluble C5b9. So this is quite interesting. This is showing that the production of the membrane attack complex is quite reduced here, but we cannot really explain why it increased in patients with eculizumab, as these patients also showed reduction in the hyperinflammation. So in summary, both studies, the clinical trial using eculizumab or the compassionate program using ME101, indicate that inhibition of either C3 or C5 appears to be safe and effective for patients with severe COVID-19. We found many similarities between C3 and C5 inhibition, inhibiting hyperinflammation or decreasing hyperinflammation in these patients, and this correlated with amelioration in the pulmonary function and ability to wean patients off oxygen supplementation. But he also observed some differences in the biological characteristics of C3 and C5 inhibition, either on the net formation that was still high when C5 was inhibited, or in the complement cascade, in which we saw this factor B consumption or decrease when C5 was inhibited, but not when C3 was inhibited. So the complement cascade appears to be, based on these data, promising target for patients with severe COVID-19 to reduce hyperinflammation in these patients. And the compstatin ME101 appears to be more potent to inhibit complement, at least in this set of patients with COVID-19. So I'd like to thank first your attention, but I'd like to thank my collaborators, Professor John Lambris at UPenn, Antonio Risitano at Naples, University of Naples in Italy, Fabio Ciceri, that is at Ospedale San Raffaele in Milan, Italy, but also Dr. Dimitris Mastelos from Greece, and here in the University of São Paulo, Bruno Pires da Silva, Professor Benedito Fonseca, and Professor Alexandre Fabro from Pathology, who performed the autopsies of these patients with COVID-19. So thank you for your attention, and I'll be happy to take questions. And of course, I'd like to thank FAPESP for the financial support.
All right. Rodrigo, thank you very much for that beautiful talk. Beautiful data, I must say, for patient data. Amazing.
Thank you. Thank you very much. Yeah, that was the correlation that we see with the decreasing the inflammation parameter of inflammation cytokines, either CRP or LDH. This clearly correlated with the clinical improvement in patients and how they were independent from oxygen. So that was very striking how fast these patients ameliorated from their lung function, and we can see that from these cytokine profiles.
So I had two questions. One is actually, well, you mentioned the cytokine profile. So it was clear that many cytokines dropped dramatically and some did not. So there must be complement independent and complement dependent cytokines?
But possibly. So this is a very good question. So first, either they are complement independent, or once they are generated, you might have some amplification loop also for these different cytokines, and they might remain high for a longer time. So this is another explanation for this. So and trying to sort out from C3 and C5 inhibition, we might understand that better.
Right. So some of them might be just irreversibly up, and then others are reversibly up. Yeah.
Exactly. Exactly.
So then the big question, it seems to me, is in a clinical setting, how do you decide when to administer these? And is sooner the better? And I mean, are these so safe that you would almost do it prophylactically, you know, or do you wait until, yeah.
The good thing is that I'm not working at Walter Reed, right? But I think that the sooner the better, because if you go back, the two patients who died and were able to do this biopsy, the patient had very severe fibrosis. And my guess is that that fibrosis was already in development when we started the drug Kudusumab. So this is something that was there. And when you see that level of fibrosis in the lung, it's obvious that the patient will never get back unless you do a lung transplant in these patients, right? So my feeling is that if you have parameters indicating that this patient might go bad, whether low lymphocyte counts, high CRP levels, high LDH levels, or high IL-6 levels, even if this patient is with mild disease, you should consider these patients for a preventive therapy or a preemptive therapy for either with complement inhibition or other settings. So the trial they're trying to put together now, we will try to start that the sooner the better, within 7 to 10 days of symptoms to start that.
I mean, you could imagine just anyone on ventilation, it's time or something, you know.
Yeah, exactly.
So I think Andrea has a question. Can we unmute him? Yes.
Can you hear me?
Yes.
Oh, okay. So sorry, I missed the first couple of minutes of the talk. I was wondering, so there has been a paper from Colombia in Nature Medicine on the implication of complex system proteins in COVID-19 disease severity. Was your hypothesis for using this drug based on that, or was it an independent mechanism that you were after?
So what the hypothesis to do that was, first of all, because of part of this study also from Colombia, but we had some animal models for the SARS-CoV, not SARS-CoV-2, but SARS-CoV, using the C3 knockout mice, showing that they had way less lung infiltration, lung damage when they were knockout for C3, showing that the complement was mediating this inflammation in the lungs in the mouse model. So this was the first thing. And then some evidence was building up in terms of the clinical data and showing that complement was activated in these patients.
Yeah, it was striking actually, especially for people with macular degeneration. There was a striking association with disease severity. So it was a very interesting finding. And I didn't know there was a mouse knockout model that actually showed. So this was ACE2 activated model, or?
This was, I have to remember, it's ACE activated model, if I'm not mistaken. If I can show you the slide again.
Yeah, sorry, I missed that.
Yeah, no problem at all. So yeah, this is the model. So this is the C3. So you can see as early as day 2 from infection from SARS-CoV, you can see C3 deposition. Not, of course, in the knockout, but we can see that the cytokine here in blue are the knockout animals. So cytokines are really down in these animals here. Yeah. So this is the rationale. The
beautiful study.
Yeah. No, that's very interesting.
So I guess I have one of the, do these C3 knockout mice have issues? I mean, you might imagine they would have phenotypes.
Yeah, they do have phenotypes. Since they live in this cage that is germ-free, it's not a big deal for them, but they are way more susceptible to encapsulated germ infection. This happens also to patients received with a PNH that we treat. So we vaccinate them against meningitis or pneumococcal because of the high risk of developing these bacterial infections.
Yeah, you would fear the drugs might phenocopy that issue. Yeah,
exactly. Yeah. That's right. So these patients, they receive, but receiving penicillin, that's quite safe, and we've been treating these patients for over 15 years, and the number of cases in which that happens, you can see that the patient was not taking the pills anymore.